first, Andreas.
These are very interesting talks indeed. My question is, you know, being an editor makes me a little bit, you know, curious about some methodological details. It is a question to Dr. Peradze. Congratulations on the trial. These results are very stimulating. I was wondering one methodological detail. You powered the study for a difference in quality of life and so on. How did you deal with the fact that the baseline breast Q values were already higher for the patients that received robotic mastectomy?
So, thank you very much for the question. Obviously, it is quite difficult to understand the initial situation, but the patients anyway were very comfortable with the robotic nipple-sparing mastectomy, and this trend also evaluated after 1 year of the surgery was basically the same. So this is basically the trend. Yes. Yes, yes.
Did you perform blinding? Because we know from the literature that studies that are powered to detect the quality of life differences are biased if they are open label. Did you employ blinding?
Sure.
Yes, but was it a blinded trial?
Yes, the patient did not know about they was informed about the procedures. So
the women, did they know that they were going for a robotic mastectomy or an open mastectomy?
Sure.
So they know it. So it was open label. Thank you very much.
Yes.
Thank you very much.
Okay, other question? I have a question for Pedro. So Pedro, this is amazing, you know. Years ago, at the beginning of 2000 with Giuseppe, when he was with me at the National Cancer Institute, we tried to create a sort of breast cartography. You remember Giuseppe using a MRI or, you know, ultrasound was not so easy at the period of time, you know, it was not so important to try. But nowadays we are on time off, you know. So on time to do this. And my question is, this is really fascinating. Do you think that we can use as a tool for teaching breast surgeons, for example? Do we have any possibility to use this kind of, you know, so-called methodology?
Yes, so that is a quite interesting question, and it's a fascinating world. So if you need to think on the problem. So when you have a surgeon that applies for a specific course, he goes for the course, and then he go back to the hospital, and he does not have his mentor where he has learned. So because we didn't have the tools, not anymore. So we already have video conferences, but only video conferences are not enough. So even if you use phones or iPads or external cameras, that is not the ideal because it will be tired, and you cannot teach him, for example, how to do a different skin incision or how to point out a specific anatomic structure. Now with HoloLens, you can have access to the surgeon's view while operating, and your mentor far away could be online seeing what are you doing, and he can propose you even in the beginning of surgery where to point out the skin incision. So he can draw the skin incision within the HoloLens on augmented reality world and to assist him on how to do it. And once he gets in surgery, he can point out also specific structures that he has to identify and to care about. So it is possible. So what we need is just to find the right methodology to evaluate surgical education performance using augmented reality or surgical virtual education with remote telementoring. So that will lead us on how to train faster and with performance a future surgeon, whether a breast or on another area. It will happen.
I have a question for Nicola Perazze. So you showed us, or you mentioned that you use 2.5 centimeter are enough, to carry out the mastectomy. One of the main problems related in using breast implants and then narrow skin incision lead during the time on damages to implant, because one of the main reasons of implant rupture in the first 10, but also after 10 years, are more related to iatrogenic damages, like, stress of the shell, if you need to insert for a very narrow incision, and later on there is a rupture. So you showed us a big breast or medium breast, we can say, So it means that, do you use anatomical implant?
Yes.
So it means that a cohesive gel, how can you introduce a 13 or 14 diameter through a 2.5 centimeter?
So as you can saw from the video also, nowadays we did not have any problem for this issue. I don't know about the long-term results. Maybe it will be result in the damage, as you said, in the future. But honestly, obviously, during the surgery, maybe this incision getting a little bit more longer, while anyway there is a small retraction of the skin, so maybe it is getting a little bit longer. So, but nowadays we didn't have any problem with this.
And last question, but
sure.
Is a remark, is another question. Generally speaking, when we talk about contamination of implant, we know that the best solution is through the IMF, because you don't touch the breast, and in the axilla area, the other reason is you are full of glandular related to the skin, and so are more prone to contamination. You don't have any increase of implant contamination in your series? No.
We did not saw any infection-related complications. Just as I showed, I think only one patient in the robotic group has the infection, and therefore the implant loss. But at the time being, we did not have these major complications. Obviously, we perform all the antiseptic procedures before introducing the prosthesis, and that's it. So
because contamination lead to a capsule contraction or
sure.
ALCL, so you have to
Absolutely.
follow your patient for
strictly for a long time. Absolutely, sure.
Okay. We have a question.
Congratulations, a very inspiring talk. I have a question. You showed a couple of papers at the outset about the nipple whipple, for example, stress and problems in the surgeon. Did you look at the quality of life in the operating surgeon and DASH scores and that sort of thing pre and post-op?
No, we didn't do any study about this. We just know, this is my opinion only, and as a surgeon, to be honest, and I agree, to be honest, that nipple-sparing mastectomy is quite challenging when performing because of the limited incision, and as a surgeon, you also know for sure that it's quite fatigued to perform nipple-sparing mastectomy from the small incision, and the difference as I can perceive this, is much ergonomic to perform the robotic nipple-sparing mastectomy sitting on the console and doing it like with the joystick. But we did not do any scientific, there is no scientific evidence from us.
I just wonder if the future RCTs should look at this aspect
Absolutely.
as well as patient satisfaction, which seems to be high throughout. Yeah.
Sure.
Okay.
Thank you very much.
Amit, I have a question for you. So your approach is easily reproducible, or we need a learning curve or particular devices to be able to do this? Can you hear us? Amit?
Sorry, I missed out half minute, sorry.
Just to know if it is easily reproducible, your methodology to reach this kind of cartography of the breast, and if you need particular devices, I mean.
Yeah, well, it's interesting. I think, Pedro, you mentioned about you gave a reference. So 3-4 years ago, I was kind of one of the guys, they were there in Cambridge for some study, and I was talking to them, happened to talk to them, and we were talking about HoloLens, and you know, that was one thing that kind of led me to think of a study looking at 3 dimensions, because it's difficult to get your head around. And second, when, you know, you probably have seen in theaters when we do bilateral myoplasty, I think many times the trainees are focused trying to match what's coming out. You know, it's 500 gram. Oh, Mr. Well, it's 510 gram. Let's take 10 grams more out. And what I was trying to impress, it's what's important, what's left behind, not what's coming out, because you know, one side could be maybe a cup bigger breast, it could be more deeper breast. So specimen weight, multiple dimensions, that was the intention, trying to understand and explain. Whether it's going to be reproducible, well, this was a single surgeon study, so we all have our little ways of operating. So I'm not sure whether we could replicate or reproducible. You know, it could be, there could be surgeons better, there could be surgeons not so better. Okay. If that answers the question.
Yeah, thank you. Any other question? We can go ahead. So thank you, Amit, to stay with us and connected until now. And
thank you.
Thanks a lot. Thanks to all the other speakers here. And we go ahead with Marzia. Marzia,